Good afternoon. I'm delighted to welcome you all to this installment of the Johns Hopkins Congressional Briefing Series, where Johns Hopkins experts provide a briefing on a topic of interest to policymakers and engage in real-time questions and answers. This discussion, Disability Justice, Translating Research to Policy, is a timely conversation as July is Disability Pride Month. My name is Swenor, and I'll be moderating today's briefing. I'm the founding director of the Johns Hopkins Disability Health Research Center and an associate professor at the Johns Hopkins School of Nursing. To set the tone for inclusion for today, we have captioning and ASL interpreters for this event. We'll provide visual descriptions of ourselves to support access. My visual description is that I'm a middle-aged white woman with shoulder-length blonde hair wearing a dark suit jacket and a light-colored blouse. I use she, her pronouns, and I identify as having a disability. In today's briefing, our panel will discuss how to translate research into policy through a lens of disability justice. Disability justice can be broadly interpreted as the process of addressing the inequities impacting disabled people. This work is grounded by a framework developed by disability scholars and activists, including Patty Byrne, Stacey Milburn, and Mia Mingus. And that framework centers the tight interconnection between the inequities and injustices that disabled people face to all other forms of injustice. Efforts to make society more inclusive for people with disabilities has resulted in great progress. Yet there's often a disconnect between the disability community, researchers, and policymakers. But today, we will address why these gaps exist and how policymakers can work to better align the data with decision-making. I'm pleased to be joined by 4 of my Johns Hopkins colleagues. Dr. Judy Bass is a professor at the Johns Hopkins Bloomberg School of Public Health. Her areas of expertise include designing and evaluating methods for assessing mental health across populations and contexts, and evaluating innovative strategies that support mental health. Dr. Bass will discuss mental health as it relates to disability justice. Dr. Linda Carling is the director of the Center for Technology and Education at the Johns Hopkins School of Education. She has nearly 2 decades of research experience providing individuals with accessible, meaningful, and engaging learning opportunities, both in person and virtually. Today, Dr. Carling will discuss accessibility within education. Dr. Jack Iwashyna is a Bloomberg Distinguished Professor of Social Science and Justice in Medicine at the Johns Hopkins School of Medicine and the Bloomberg School of Public Health. His primary expertise is on how patients and families can heal from acute serious illness. And today, he will address the effects of long COVID through the perspectives of disability justice. Dr. Jennifer Deal is an associate professor at the Johns Hopkins Bloomberg School of Public Health, and her research examines how people age with vision and hearing impairments, as well as other types of disabilities. And she's examined how missing data can impact our understanding of that aging process, particularly dementia outcomes for those populations. Today, she will discuss the inclusion of individuals with disabilities in clinical trials and in research studies. And Janiece Taylor is an assistant professor at the Johns Hopkins School of Nursing. Her research focuses on identifying and addressing disparities in pain in older women from underrepresented racial, ethnic groups, and improving health outcomes among older adults with disabilities. Today, Dr. Taylor will discuss the needs of caregivers with disabilities. And before I turn to each of our panelists for their remarks, I want to remind all in the audience that we will be providing answers to your questions in real time. So please submit questions for our panelists in the box at the bottom of your screen. And now I'll turn it over to our panelists for a brief overview of today's topics. I'm going to start with Dr. Bass. Judy, question for you is, for your perspectives on how mental health and mental illness relate to disability justice?
Thank you for having me join today. My name is Judy Bass, and I'm also a middle-aged white woman. I have long red hair, and I'm wearing a burgundy top today. Mental health disability has received less legislative and policy focus than disabilities associated with the physical body. There are probably many reasons for this, including a lack of understanding of mental illness and stigma. For mental health disorders, disability is often treated as a byproduct of the illness, with the assumption that if the mental health condition is treated, then the disability will be ameliorated. Well, mental health disorders can be managed, and sometimes people may only experience a single episode. More typically, they are actually chronic conditions, similar to many physical chronic conditions that need lifelong management. Even as research is being done to gain a better understanding of the causes and treatments for mental illnesses, there continues to be significant stigma and problems of access to care for people with mental health conditions that intersect with issues of disability justice. People living with mental health conditions often face stigma because of their behaviors, their thoughts, and their expression of emotions. For example, when a person with schizophrenia is experiencing hallucinations, they may act in a way because of stigma and misperceptions that is confusing or scary for people around them. This is a disorder of the brain, and it can impact many areas of daily life, basically a disabling condition, which is true of many mental health conditions, ranging from developmental disabilities through to severe mental illnesses. However, because of stigma and a lack of understanding, people with mental health conditions are frequently limited in their access to work and social services, good education, and appropriate care. And while all demographic groups are impacted by mental health, the challenges of access and stigma are exacerbated for people of color, people living with physical disabilities, immigrants, and people with limited economic means, including unhoused people. For example, I was helping to evaluate a talk therapy project for pregnant women and new mothers who had received funding to move to telehealth services, which could increase access for some, but they had not figured out how to provide phones and phone time to women who did not have regular access to personal phones, despite serving a low-income community. And they had not considered how to provide services for deaf women or women who needed available services for using telephone, despite acknowledging that these were women in their community. My research focuses on increasing access to effective mental health services in contexts where few mental health professional workers exist. To do this, we need to not only engage the available social health and service sectors, but we need to work with and listen to the people who will use the services, people with mental health conditions and their families. And not only those who are well supported, but we need to hear from the full range of people who could access the services so that we can develop service systems that reduce stigma and increase access for everyone. This means including historically left out and marginalized groups of people, including those with more disabling symptoms and physical disabilities, in the development of mental health service systems, not just as recipients. Policies that encourage this inclusion and support best practice guidelines for more inclusive services will help reduce barriers to care for all people with mental health conditions.
Thanks so much, Judy. Certainly conversations around mental health and mental illness have been elevated in light of COVID-19, and really grateful for your work and important comments about being equitable and thinking about diversity in those efforts. Now I'm going to turn it over to Linda for another really timely conversation about education. The question for you is to talk about what challenges people with disabilities face when it comes to accessibility within education.
Thank you all for the opportunity to speak with you today. My name is Linda Carling. I work in the School of Education at Johns Hopkins, and I'm the director of the Center for Technology and Education. My visual description is that I am a middle-aged white woman with blonde hair. I'm wearing a light-colored shirt, and my pronouns are she and her. Accessibility in education directly impacts quality of life. Most basically, it improves academic outcomes and graduation rates. It equips students with disabilities with the skills and confidence they need to navigate the world beyond the classroom. And it prepares them for employment, higher education, and independent living. According to the 2023 annual report on people with disabilities in America, of people with disabilities aged 25 to 34 living in community settings, around 13% do not have a high school diploma, compared to around 6.5% of people without disabilities. And around 20% of people with disabilities have a bachelor's degree or higher versus 41.5% of people without disabilities. And of people with disabilities aged 18 to 64 living in community settings, around 41% are employed versus around 77.5% of people without disabilities. So just starting with some statistics here. Access to quality education is a fundamental right for every individual, regardless of their ability. Accessibility in school is essential for building inclusive societies and empowering individuals to reach their full potential. When I speak of accessibility in education, I'm referring to the removal of barriers that promote equal opportunities for all students. And this goes beyond physical access, which is what many people think of when they think of accessibility. It means curriculum access, communication access, technological access, socio-emotional access, and access to support services. So we know the benefits of accessibility in education and likely can agree on the need for them. But why is this such a challenge? Why is this not happening for our students? A fundamental barrier to access is ableism. Ableism is the systemic oppression of disabled people. It's the actions and beliefs that assign them lesser worth than non-disabled people. And this bias is used as a justification for exclusion. Evidence of this can be astonishingly obvious, but much of the time it's subtle and easy to miss. Just speaking from personal experience, which is what drives the work that I do, is I have two children in local public school. My 11-year-old son is autistic, and despite the fact that a large part of my job is to improve outcomes for learners with disabilities, and I use that expertise to advocate for him, for my son, he still struggles with accessibility every day. And I'd like to share a simple example. Just, there are plenty to choose from. I just want to share a simple example of an access issue that my son encountered recently. After a year of playing percussion in the band, it was time for the end of the year concert. I was excited to see the culmination of a year's worth of practicing. When I saw him on stage, I noticed he was given a practice drum pad to play in the concert instead of a real noise-making drum to play, which was surprising to see. And I did some digging and really discovered that they did not expect him to perform up to par in the concert. So he was given practice drums, and it didn't occur to anyone in the school, except for me, that it was a problem, or perhaps something they should, share with me before the concert or something we could discuss. And my son bought right into their low expectations. He told me, it was okay, that he wasn't expecting to shine in this concert, and he just wasn't sure if he should even continue playing percussion next year. So, it's one example, but it's a good example of how an institution ticked the box of accessibility by giving him, physical access to the stage, but fell short of true access by excluding him from not only everyone on the stage, but the whole point of a musical education, which is to be involved in produce music. So this happened to my son, who's backed by all the advantages and resources that I have, backed by high level involvement in his education, hardworking teachers, partnerships with teachers. Teachers are well trained, in this case, and private services that we're privileged enough to give him. So we still encounter these issues. Children with disabilities who are facing additional systemic barriers and discrimination, such as racial or socioeconomic inequalities, have even less access to resources, opportunities, and quality education. So we have work to do. These barriers continue to perpetuate social inequalities and further impede children from fully realizing their potential. And we have to be mindful of the unique challenges faced by individuals at the intersections of multiple marginalized identities. So what can we do about it? So at our Center for Technology and Education, my focus is always impact. We work hard to solve tough problems creatively and to achieve access to opportunity and success for all learners. The centers have a unique role in our School of Education. We bring people together with focus and purpose. We forge relationships in the field with teachers, educational leaders, and policymakers. And we're entrepreneurial and innovative. We leverage technology in our solutions, and our projects impact teachers and children. And our work at our Center for Technology Education focuses on special education and instruction and assessment with lenses of access and equity. And our work includes implementation of data systems, research, and professional development for educators and for leaders. We've learned that in many cases, small changes can make an incredible difference for a student. Imagine a classroom where students with disabilities can access the same educational resources, contribute their unique perspectives, and learn alongside their peers. So to address the diverse needs of disabled individuals, to promote more inclusive environments and combat inequity, principles of both accessibility and intersectionality must be applied. So for example, inclusive design practices can amplify the voices of people with different backgrounds to ensure that products, services, environments are accessible and usable for everyone. And to eradicate ableism, we need a significant shift in mindset that involves recognizing, challenging, and dismantling the attitudes and beliefs that perpetuate discrimination against people with disabilities. Advocating for accessibility plays a big part. Educators need to be mindful of the unique challenges faced by individuals, at the intersections of multiple marginalized identities. True accessibility in education requires a collective effort. Educational institutions like ours, policymakers, teachers, and communities must work together to create an inclusive educational ecosystem. And this involves adopting universal design principles, investing in assistive technologies, and ensuring that physical infrastructure is designed to accommodate all students. Funding is needed for pre-service and in-service teachers, for continuous learning about disability issues, and to challenge any preconceived notions or biases, conscious or unconscious, that they may hold. We need to help educators unlearn any harmful ableist beliefs and adopt more inclusive attitudes. So accessibility in education is not just a matter of legal obligation, it's a moral imperative. And it's about ensuring that every individual, regardless of their ability, origin, race, gender, sexuality, or socioeconomic status, has an equal opportunity to learn, grow, and thrive in a world where they can safely bring their whole selves. I look forward to continuing our work together to create a future where education truly knows no barriers. Thank you so much.
Thank you so much, Linda. Really appreciate your work, sharing your personal story and your powerful comments. You and I have certainly had some good conversations in the past about how important education is and the work you're doing, the work your center is doing to make the changes you outlined. And what you said really is right. It takes a team effort. Thank you so much for sharing all of that. Really, just so critical. Education is key to all of this, I believe. I know you do too. So thanks. I'm now going to move it over to Jack. Really grateful for you to be on this panel as well, and love to have you speak to the audience about long COVID and why it is so important to understand long COVID from a lens of disability justice.
Absolutely, Bonnie, and thank you so much for the opportunity to offer some preliminary thoughts. So I'm Jack Iwashyna. I'm an intensive care unit physician, which means it's been a busy couple years for me. And visually, if everybody else is middle-aged, I'm an older than middle-aged appearing white man with a beard and a balding haircut and a blue shirt on. And watching my translator work with me, describing my balding at the same time, is a fascinating experience that I appreciate Bonnie for. So let me get actually to hear what I'm supposed to be here for. So long COVID, there's a lot of it. There are maybe 6 million hospitalizations for COVID as of May 2023. Those have continued after the end of the public health emergency. And we know only a small fraction of patients who have COVID were hospitalized. We know that there are a wide range of symptoms and that the science is still evolving as to how we will define long COVID, whether it will be defined narrowly as something that happens only after COVID, or whether it will be defined broadly to encompass the wide range of pandemic effects on patients and their loved ones' ability to function. We also know that there are some early cardinal symptoms, especially fatigue, cognitive impairment, and lots of exacerbations of other symptoms and other existing conditions that limit people's ability to function in the world in the current set of expectations. And I would say my best guess is that it's unlikely to be just one thing. It would be wonderful if the COVID virus happened to influence just one particular T cell receptor, and we could fix that one T cell receptor, and that would make anything and everything better. That's probably not going to be the way it plays out. There's going to be a host of different interacting mechanisms, the balance of which will be different for each individual person, and which from a policy front, we need to be able to incorporate that diversity of effects in order to help people fully recover from these last several years we've been going through. So I spend most of my day playing with physiology, and when I'm in the ICU, altering drips and ventilators. And so an understanding of the physiologic basis of disease is essential. But when Bonnie asked me to join our conversation today, I think she was also challenging me to ask, where is that going to be inadequate? And what does a disability justice approach to long COVID ask us to center about people's experiences as opposed to individual organ function or individual cell function? And I think the first point is exactly that disability is about people's ability to go out and be in the world and for the world to have the benefit of their genius and their talents. And doing so requires us to understand the way multiple things interact, not to reduce a person to simply any given biological marker. And so that one of the places disability justice pushes us to do better as physicians and as a public health system is to ask, how do we center the impact and understand the impact on people? It also suggests we need to understand that it's not a single viral hit that's going to have influence. Instead, there'll be sequential behavioral adaptations. That's going to be a process of generating different capacities. And we want to understand long COVID as a process rather than long COVID as a single entity that there's going to be some magical imaging or biomarker test for, that then once they're above that threshold, they have it. And once they don't have it, they don't. If we're really interested in understanding the effects of the pandemic, as opposed to just trying to track a level, we want to understand those multiple interacting effects. Doing so means we need to think about impairment generating environments and the ways those environments might be impairment generating, that is exclusionary or inclusionary. To take the easiest example here, many of us have different eye functions. For me, with my glasses, with adequate lighting, I'm able to perform my job as an ICU. In the dark, without an individual adaptation, I can't see a chest x-ray well enough to be able to read it and do my job. How can we think about creating environments that don't depend just on the shape of our eyes, but on giving individual and environmental adaptations to help patients who are recovering from whatever their sequelae of COVID are to move forward? Doing so then means we need to promote research that looks at how we change the environment and the demands that environment places on a biology, as opposed to putting all our eggs in one basket of hoping that there is some magical process that will automatically reverse the biology of COVID. Doing so means also being a little modest about where we are at medicine. There are some things we fix, and I love that. And as an ICU doc, I love to fix things. But when you think about patients who have heart attacks or strokes, which are perhaps been at the very center of the research we've been doing for the last 60 years and the research American medicine has done best, so many of those patients go on to have ongoing differences in organ dysfunction. And it's impossible even for those conditions for which we have such great systems for us to get people all the way back to who they were beforehand. And so if that's true, we need research that takes into account the reality of ongoing changes, even after best possible care for long COVID, and that thinks about how these millions and millions of Americans can then contribute their best to our social life. And doing so means thinking about access to care. And I'll end here by asking you to imagine those of you who have private health insurance, the last time you tried to get a primary care doc appointment, or the last time you tried to go even get a dentist appointment, and how long that took for you. And if you're on this call, you're a pretty sophisticated user of American bureaucracies. But I'm still guessing it took you multiple calls, multiple efforts, multiple frustrations. Now imagine overlaying that with a degree of brain fog, a degree of fatigue, a degree of anxiety from COVID, and how much harder it's going to be if we over-depend on individuals to have to navigate the healthcare system, than if we develop a healthcare system that can help patients and their families who have long COVID pull forward in to get the best of the care that we have to offer them to make sure that they can contribute. And with that, I will thank my translator colleague for doing such a great job with me, and thank Bonnie for having me here.
Thank you, Jack. Always appreciate working with you, and so grateful for those comments, particularly the access to care, which is front and center in lots of policy decisions, our conversations right now. Always value how your work makes such important connections between centering on the patient, on the individual, and making connections all the way back to organs and cells, and just how rare that is. And just much thanks to you for all of that really critical work. Thank you. Now moving on to Dr. Deal, Jennifer. Excited to speak with you and your important work. I'd love to hear from you about the inclusion of people with disabilities in clinical trials and other types of research. I know this is work you think much about.
Thank you so much, Bonnie. I really appreciate the opportunity to be here and talk about this important topic. I'm a middle-aged woman. I'm wearing glasses and a dark suit jacket. I have light blonde hair that's pulled back in a bun. I acknowledge my positionality, which is as a self-identified cisgender white woman. I use the pronoun she, her, and I identify as non-disabled. So to kind of frame the importance of this topic, data from clinical trials and from other types of population research studies are needed to guide clinical and policy decision-making. We need diverse research populations to be able to maximize the generalizability or the applicability of those results. And we know that there are differences among people, including differences by age, gender, race, ethnicity, and by disability, that can impact how well an intervention works for them. And importantly, it might not just be one of those factors, but a combination of those factors, thinking about how they all intersect, that may also impact how well an intervention works. Unless we include disabled individuals in our research studies, we can't know how well an intervention works for them. And that leaves us to make decisions about their clinical care and about policy without an evidence base to support those decisions. From a social justice perspective, when we fail to include individuals with disabilities in clinical trials and other research, this perpetuates the marginalization of this community. And research that we've done really highlights this inequity. So for example, using clinical trial data, we've shown that the effect of cognitive training interventions, which is an intervention that's been shown to improve the health of older adults, the effect of that intervention differs depending on whether you have sensory loss. And in fact, training can even be more helpful for people with sensory loss. But in a systematic review of 130 cognitive training intervention trials, nearly 60% of studies systematically excluded people with sensory loss. So people who were most likely to benefit were excluded. Additionally, less than 1/10 of those studies considered accessibility for low hearing and low vision in the intervention design. This exclusion and lack of access to the intervention is not scientifically justified. Action is needed to advance the inclusion of people with disabilities in clinical trials and research. At this time, I can't simply go to the literature and read about a clinical trial and understand how many participants in that study were disabled. And that's because it's rarely reported. So action needs to be taken to include disability, understanding the importance of intersectionality as a core demographic that's collected and reported in research. As with current mandates for gender and race, ethnicity, and age, disability should be designated as a minority group and a population that's affected by health inequities. This action would ensure that members of the disability community can benefit from established resources to increase diversity in research. Exclusion from participation should not be allowed without scientific justification. Additional sustainable funding is needed to ensure that participation in research is accessible to people with disabilities. For example, funding and grant applications should support accommodations and universal design for mode and location of data collection. Novel grant mechanisms to develop these methods is also needed. And an important part of this effort is also funding in order to train researchers on how best to implement these methods in their research. We need the disability community to be a partner at all steps in research. In addition to thinking about more diversity in research participation, we also need more diversity in the lived experiences of the individuals who are leading this work. The National Institute of Health is working to address inequity in the inclusion of disabled people in research. The Advisory Committee to the Director Working Group on Diversity, Subgroup on Individuals with Disabilities, which was co-chaired by Bonnie leading this discussion here, as well as others, released a report in December 2022 with some excellent suggestions to advance this effort. And those suggestions included leading the creation of a National Institute of Health Office on Disability Research. This is a dedicated infrastructure that would support, coordinate, and advance the inclusion of people with disabilities in research, but sustainable funding is needed in order to support and move this effort forward. Thank you.
Thank you, Jennifer, and thank you for all of your work really quantifying and highlighting the bias, the impact on our knowledge and inference from studies when we exclude people with disabilities, all types of disabilities. And thanks for calling out the NIH report. That's much appreciated. And I know you are thinking deeply about how to close these gaps and how we can do better. And certainly everyone should pay attention to more of that coming from you. So thanks so much.
Thank you.
And now moving on to my colleague at the School of Nursing, Dr. Janiece Taylor. Thanks so much for being here. So Janiece, you have some really critical, important work going on right now, and would love for you to share with us a bit of that and discuss why caregivers with disabilities really haven't gotten the attention that they deserve. Why is this an important area of focus in research, really focusing on caregivers that also are disabled?
Thank you so much, Bonnie, and to all of my wonderful colleagues on here for your tireless effort and work that you do for disability justice. I am Janiece Taylor. I am an African-American or Black woman. I have on a black jacket and underneath a light pink dress, and grateful to be here this afternoon with you all. There are approximately 53 million caregivers, family caregivers, meaning they are unpaid within the US. And that translates to about 1 in roughly 5 or 4 older adults who serve in the role as caregivers. Along those lines, there are 1 in 5 adults who have some form of a disability. So it is very likely that family caregivers may be aging with or into disabilities themselves. And this is a very critical and important area when we think about social determinants of health and inequities that impact individuals with disabilities. An individual who is intersecting at being a family caregiver as well as a person with a disability, they're experiencing inequities that they've aged with, as well as trying to navigate through the healthcare system, social system for the individual they may be caring for. And to give an example to you all, I went to interview a research participant in her home. She was a woman in her 70s who was aging with chronic pain. And she asked if it was okay if her daughter was there, who was her caregiver. And I said, of course, by all means, to help her navigate through the study. And when I arrived to her home, her daughter was there and she had a mobility limitation, a physical disability herself. And as I watched her daughter attempt to navigate through her mother's home, and she knew all of her mother's medications, her appointments, I couldn't help but realize that her daughter had her own health, her own inequities that she had dealt with to navigate as well. So there is this layer of being a family caregiver and taking care of someone yourself as well, that this population often is unserved. They are often excluded from um, research studies, as my colleagues have pointed out, because of some of the chronic conditions that they may have, or just accessibility, being able to access studies. But also, if you're a family caregiver who has a disability, you're working, you're not in the community as others are. 61% of caregivers still are trying to find some way to work as well as continue in their caregiving responsibilities. 51% of caregivers do discuss difficulties financially as well that they have in that caregiving role. So we know that there is a huge impact financially and achieving healthcare for individuals with disabilities. So combining this with being a family caregiver can be taxing. Now, we know that the caregiving role can be rewarding, and many people take great pride in that role. However, within social systems, within our healthcare system, there are significant barriers that they do face to getting care for themselves as well as those that they care for. And most caregivers that we work with in our research within the community are very happy in this role, but many of them did not expect to take this role. If you can think of an individual who has a disability themselves, whether it is physical, sensory, whatever type it is, whether it's intellectual or developmental, and they may have a spouse or a partner who has a disability that is unexpected, they have to take on that role. There are also parents of children who have disabilities who are aging with disabilities themselves. I witnessed a woman who had a severe mobility limitation as well, and she had an adult son who had an intellectual disability. And in this specific observation, they were in the waiting room to see the doctor for her son, and he was becoming very agitated. And she was trying to navigate and calm him down, but she was experiencing great difficulties in this tight waiting room in helping him to calm down within this setting. And as we age and children with disabilities age, this is a huge concern for parents who may have disabilities themselves. What is my health going to look like? How is my child going to be taken care of when I'm no longer here? And as a nurse, it is so important that there are policies in place within our healthcare structure within society to meet the needs of these caregivers who have disabilities themselves. I am also the assistant director of the Johns Hopkins School of Nursing Resilience Center. And within this center, the mission is to improve the health and function of people with disabilities and their caregivers by developing and adapting evidence-based interventions. And that is part of the work that I'm doing, is to learn about the unmet needs of caregivers with disabilities. However, there's not a great deal of literature out there that we can go to and find out how many are there out there and what are their needs. We're really starting from the ground up to learn about this population. So we are in need of funding and support and policies in place to truly improve health outcomes and social participation for this group. Thank you so much.
Thank you so much, Janiece, for all of your really important work, and for elevating, the structural inequities and the compounding of those inequities, and the nuanced conversation around caregiving, and particularly when we're bringing in the conversation of people with disabilities who are caregivers, such a under-discussed topic. So thank you so much. So now I'm going to encourage our audience to type in their questions for our esteemed panelists today. And I'm going to start with some that have already been received. And the first question for this group is about participatory research. The question is really asking about how each of you is implementing research that includes people with disabilities or people in the communities that you work with in your studies. If you could talk a little bit about how you're doing that and what that might look like. And Judy, I'm going to start with you.
Thank you. Yes, we are doing participatory research and doing research on ways to include a broad range of people. So one example is I do work here in the US and I do work internationally. And one of our projects in India is looking at how to integrate mental health services into TB care. And so the first step that we are doing is that we're actually having conversations and doing qualitative research with people with lived experience, both of TB survivors, as well as people with co-occurring mental health conditions, and making sure that we are including them in the conversations really early on what kind of mental health services, what would they want them to look like, where would they want them to be delivered, and importantly, who would they want them to be delivered by? And so really getting the input into service delivery development from people who will use the services, as well as the doctors and the systems who will be thinking about how to deliver it. And one of the things that we emphasize is that when we bring in researchers, when we bring in collaborators, whether they be academics who sit in a university or community-based organization collaborators, or members of the community where we're working, we have to think about their time being valuable, just as valuable as the time of the researchers. And so there needs to be pay. There needs to be funding for participation of our community partners. We can't expect them to be volunteering their time. These are typically marginalized populations already. And so I think one of the really important aspects of doing participatory research is that everyone who's participating gets remuneration for being a member of the research team. And so that's something that we prioritize, as well as prioritizing inclusion of a full range of people and making sure that we're thinking about intersecting identities, and not just the health identities, but also the lived experience identities, the disability identities. So that's one way that we're doing this work.
Yeah, thanks so much, Judy. That remuneration, the payment for time is such a critical issue and is certainly a policy issue and really does help support the diversity of the perspectives that we can include. Linda, over to you. Can you talk a little bit about bringing communities to the work and education that you're doing?
Yes. So we're doing a lot at the Center for Technology and Education involving communities. We have a number of projects, and our projects impact, all students. So it's really important that we don't bring our assumptions into the work, that when we approach projects and working with educators in the field, and that we are actively involving and having the voices of these teachers and leaders from diverse backgrounds and experiences in helping to shape the research that we do, the evaluation that we do, and the supports that we provide for them. Just as an example, we do a lot of work with early childhood assessment, and we are looking at assessing all learners and how we can make the assessment more accessible for students with different backgrounds and students with disabilities. And we've involved educators multiple educators to not just make the items themselves accessible for students, but taking a step back and making the experience of engaging in the assessment and the information we get from the assessment to be useful for a variety of students and for educators. So it does take, we're certainly learning a lot, and just across the board, however we can work toward amplifying voices, amplifying diverse voices, and including diverse voices as part of the process and in every step of what we do is we've found more success and learning as a result.
Yeah, thanks so much, Linda. It's so important to bring in those perspectives in the work, and thanks for sharing and how that's happening in your work in education. That's so important. And Jack, to you.
So let me be a negative Nelly. Let me say not nearly enough. So I would propose that we do the usual things, right? We have some clear partners, and we always involve some qualitative work, and we and do some member checking. But the real answer is not at a level of partnership. So if you ask me the question, am I meaningfully partnering with the disabled community in the way that I am meaningfully partnering with a biostatistician, and you held that as the team standard, the answer would be no. And if you want to know why, I'd tell you because I can't afford to, and we don't have the institutional infrastructure in place. That if I want to meaningfully partner with a biostatistician, I walk 1 block that way or 2 blocks that way, and I can find them, and they have a business office that knows how to incorporate them. We have an IRB that knows how to help that person work with me within the context of dealing with individually protected privacy rights and the like. And if I want to do that with a member of the community, I do not have those resources. And if I go to study section and I allocated some of my biostatistician time instead to community participation, nobody from community participation sitting at that study section, whereas somebody from the Biostatistics Guild is, and don't tell them I called them a guild, is definitely sitting at that study section and is going to recognize that. And so I'm going to propose that if you called partnership the same level of partnership that we think of as the other components, we haven't done it because although I'd like to, there are substantial institutional barriers. And so I'm doing it in a bunch of ad hoc ways as opposed to on an ongoing basis. But I'm trying. I don't know. Is that okay, Bonnie?
No, thank you, Jack. And I always appreciate you bringing the dose of reality, and you do that in the work we collaborate on. And you're exactly right. That's the reality. And I appreciate you calling it, naming it, and you're right, it has to change, right? Policies have to change to support the infrastructure to make this all happen. And thank you for always being candid and willing to say the thing.
Right. I mean, there's an old joke, and I'll end with this, that, right, I don't want to see your DEI statement. I want to see your budget. And that values are one thing, but where the money goes is how we actually enact our values. And it's an area for growth for me that I've certainly been learning a lot from all the panelists here, and I hope the community and the conversations will start. Thank you.
Thank you. Jennifer, on to you.
Thank you. I appreciate so much too, Jack, that honesty and being so candid. And I think a lot of researchers in this space feel the same way that you do. And so maybe what I can offer to this conversation is a little bit in terms of thinking about ways in which we might be able to build an infrastructure or encourage those types of collaborations. And I think a really simple way is to require it. If we have grant applications that require and support funding to bring in our community partners, then we will have people applying for and using that money in that way. So I think if we have specific mechanisms that recognize the importance of community involvement, and it's not just participation, it's involvement at all levels. You're talking about starting with the design, what outcomes are important to you. It's a much more iterative type process for designing an intervention, for example, compared to just kind of that standard, let's design and then implement it, in a group of individuals who agree to participate in our study. So I think if we recognize the value and the importance of that community involvement, then we can have grant mechanisms that support that. Thank you.
Yeah, absolutely. If you build it, they will come, sort of an approach. And certainly that is the case in many instances. Thank you. Janiece, love to know your thoughts on this.
Sure, and I agree. I wish there was a better infrastructure to support these collaborations from start to finish, and especially in between grant periods, right? To still have that relationship with the community partners that you have, and you don't have the money to pay them in between, but you still need their knowledge and their expertise. So that is one ask or recommendation that I would have. And the work that we're doing in the Resilience Center, we actually named the study Designed with You. So we do have a member of the community as a co-investigator. At least we acknowledge this person as a co-investigator. The infrastructure, as you said, Jack, isn't set up for that, but we've definitely had some support to do that. And she gave feedback on writing the grant, and hopefully we'll give feedback throughout. We also use human-centered design methods to develop this intervention to identify the needs of the community and those that partner with the community as well all along the study. So these are some of the things that we're trying, but definitely have not arrived to the level that we would like either.
Yeah, thank you so much, Janiece, for sharing that. And what you all are doing is really important, and setting a pace and a tone and example for work that needs to be done. And I know there's some really great questions coming in, and I know we're running short on time. So I'm just going to ask our panelists one final question, and hope we can be succinct in getting to the point on some policy action or specific changes. You know, this conversation is about translating research to policy to support disability justice. And perhaps each of you can make a statement or have a thought about policy that may be missing or needed or improved, or one that's working on how to do just that, to better translate research to policy to support the disability community. I'm going to go back in the same order in the interest of time. So Judy, I'm going to toss it over to you.
Great, thank you. I think given the intersection between mental health and disability and justice and stigma, I would say policies that reduce barriers, policies that focus on reducing barriers to access to services and increase availability of services, particularly when we think about mental health. It's fine and great to make it less stigmatizing and to make it more normative for people to talk about mental health and talk about disability. But if services aren't available and if they're not actually accessible, then it will only go so far. So I would talk about policies that really focus on increasing the availability of effective services and the accessibility of those services when it comes to mental health care.
Yeah, thank you so much. Important conversations right now. Linda?
Yes, I think policies around increasing access to training and resources for educators and families. And some of the questions that have come into the chat related to barriers for families, and that's a often overlooked, I think, area to have some resources and education, and just making sure to include people with disabilities, their voices in policy decisions. Very important.
Thanks so much, Linda. Jack?
Oh, let's just start at the hospital across the street, and let's just say the level of concierge service we provide for some of our highest reimbursed care should be the level of service we provide for long COVID patients and other patients with disability, and that we just want to benchmark against ourselves.
Yeah, important conversations too, for sure. Jennifer, to you.
I think we need a dedicated funding for infrastructure. You know, disability is so important in research at all levels, and I think we have work to do at all levels. So recognizing that disability is a core demographic and having a core infrastructure funded that can support kind of making sure that we're collecting that data, including participants with disabilities in our research. That would be the ideal dream.
Thank you, Jennifer. Janiece, wrap us up.
Sure. Very exciting. In 2022, we saw the Department of Health and Human Services issue the first national strategy to support family caregivers. I would just really emphasize the need to not forget that many of these caregivers may have disabilities themselves, and to adjust or make the appropriate policy changes for those that have these intersecting identities as caregivers and disabilities. And when we think about resources, support services, accommodations for the care recipient, also think about the needs of the caregivers who have disabilities.
Well, thank you. You all are pros at wrapping up on time, so much appreciation. I really want to offer my thanks to this esteemed set of panelists, Drs. Judy Bass, Linda Carling, Jennifer Deal, Janiece Taylor, and Jack. Sorry, somehow I missed you out of that lineup. Iwashyna. Thank you so much for joining us today. And thank you to the organizers and those working behind the scenes of this event, including our captioners and our ASL interpreters. And I'd like to give a big thanks to everyone who's tuned in and attended this briefing, and those who submitted questions. A caption recording of this event will be made available on this website, which is the online home of the Johns Hopkins Congressional Briefing Series. Thank you again for this really important discussion. I know all of these researchers are working really hard and fighting for the disability community. Thank you so much.